So, welcome you all. We are having this session about the San Antonio Breast Cancer Conference update. I'm Dr. Amol Akhade. I'm the host and the moderator, and I'm going to learn a lot today from each of you. So, without wasting time, let me introduce our first speaker, Dr. Nihanthy. She is consultant, medical oncologist, young budding medical oncologist from India, and she is going to talk about key takeaway points from San Antonio meeting. This meeting, of course, lasted over 4 days, and she has only 10 minutes to cover, but I think she'll do a good job. So, over to you, Nihanthy.
Good evening,
Share your
everyone.
slides.
Yes, sir. At the outset, I want to thank Amol Akhade, sir, for giving me this opportunity. And it's a privilege to be a part of such elite team of panelists, Dr. Sarah, Dr. Erika, and our dear beloved Senthil, sir. Everyone has been a great mentor to me. So without wasting much time, I'll be proceeding forward. So today we'll be discussing regarding what are the updates which have been happened by the SABS, the highlights, the trials, and further innovations. So just a brief overview, as we are quite aware that this year's SABCS has updated over various therapies like ADCs, SERDs, immuno-oncology. There was a paradigm shift. It's not only about the receptor-based treatment. Now we are going into multi-omics, adaptive and integrated therapy. My main focus of the talk would be few trials, which I've highlighted. That's going to be the lidERA, HER2 CLIMB, O5 and O2, Accent O7, Ember 3 and the Evera. And briefly, I would like to conclude, obviously, any session we won't conclude without the artificial intelligence or the future directions. So with this, I shall proceed my talk. So the SABS was a quite, as we have an expert panelist, almost 10,000 delegates, important drugs, let it be the oral SERDs, immuno-oncology, various integration of biomarkers, the ctDNA therapy was adapted. So let's look into the important trials which can change the practice. First, coming to the lidERA trial. So being in an hormone positive, HER2 negative early breast cancer setting. So we have various therapies apparently currently which are being used. Post in an adjuvant setting, not only hormone therapy, especially in a high risk, we have various CDK4/6 inhibitors, abemaciclib, ribociclib is approved. But what is so important about this lidERA trial? This enrolled almost 4,200 patients across 40 plus countries, where giredestrant, which was given 30 mg, versus the general clinical practice tamoxifen or aromatase inhibitor with or without ovarian suppression. The duration of therapy was 5 years. The primary endpoint was the invasive disease-free survival. The secondary points did they look into were the overall survival, the safety, along with the distant recurrence-free interval. So mainly, even a subgroup analysis, they've also tested into the premenopausal, postmenopausal status, the nodal burden also. So in just adding the oral tamoxifen or with the ovarian aromatase inhibitor, can we knew a second generation SERD, did it make a difference is the one thing which we need to look forward. So if you're looking into the primary endpoint, especially the invasive disease-free survival, definitely here the Kaplan-Meier graph, apparently for let it be from 0 to 12 months, there's not quite great separation. But as we proceed further, as we prolong further, let it be at 18 months, 24 months, these curves are quite well separated. Even if you look into the subset analysis by looking at the forest plot, definitely the arm which had the second generation SERD did fare better than the AI or the tamoxifen which was given. There was initially a p-value of being of 0.014 with an hazard ratio of 0.7. If you're looking into the distant recurrences, definitely the curves are a bit separated. Again, there is almost 31% risk of reduction in developing metastatic disease, which needs to be taken into consideration. Now, if you're comparing both the efficacy based on the primary endpoint, the secondary endpoint, here, if you look, this is the number which signifies us. Numerically, this was significant, but yes, this trial didn't statistically signify anything. But if you compare the 3-year IDFS, definitely the absolute improvement gain was 1.7%. Now, the question as a clinician we need to ask is, are we going to change the practice for this 1.7%? Yet maybe our elite panelists will answer that in future. And even looking at the overall survival, definitely it's immature. But there is a benefit which has been seen in the subgroup analysis, especially the premenopausal status, the node positive with high genomic quad. But already we do have in this subset various CDK4/6 inhibitors which are coming into action. So maybe a combination with the CDK4/6 inhibitors, especially the Copera trail or the preserve study, might show in conclusion. Coming to the safety and toxicity per se, I think it's manageable. Treatment discontinuation was not that great a number. So definitely this says that Gedestan demonstrate a favorable numerical outcome. The numerically, definitely this seems significant, but statistically, no. But the primary endpoint didn't reach any statistical significance. So thus, we need to look into consideration based on these values. Are we going to change our practice is the question we need to ask ourselves. Now, moving on to the second study, one in the HER2 positive setting. Cleopatra was the main study which shows that definitely adding a taxane to a dual HER2 blockade has changed our first line management. But in case of a maintenance, do you still want to consider only a dual blockade or you want to add something else was the question which was answered by this trial. This trial was very well conducted across 219 centers. Almost 600 patients were recruited in this of 300 patients each. Primary endpoint was a progression-free survival with secondary endpoints being the overall survival. Moreover, we are quite aware that the HER2 subset is a patient where the chances of brain metastasis is more. It tends to be more than 50%. So what about the CNS PFS safety levels also were looked into this trial? So again, if you're looking into the graphs, definitely let it be the median PFS or let it be PFS by the hormone receptor status. This seems quite significant. Yes, by the start, maybe after 3 to 4 months of duration, the curves are quite well separated. Initially, we are aware that a dual HER2 blockade did make an improvement in median PFS. But here, by adding tucatinib to the standard of care of dual blockade, there was a marginal improvement of almost 12 months, which seems quite significant with a significant p-value and a ZADAS ratio of 0.64. Similarly, if you're going to subdivide them again into the hormone status positive and hormone status receptor negative, we can see the gain which was seen, especially in a hormone negative subset, the benefit is 12 months. And in a hormone positive subset, the benefit was 6 months. This seems quite significant. Definitely, tucatinib addition did make a benefit both in the HR positive and the HR negative subset. Our main focus would be the CNS disease. Can we delay the progression? Yes, even did this make a difference by 4 months benefit? So I think overall this trial seems quite good. Maybe the safety profile, again, if you're looking into the safety profile data, the common side effects of either of the TKI and the dual blockade, let it be the diarrhea, nausea, yes, they are quite bothersome, but that has to be taken into consideration. The discontinuation rate was almost 13% versus 4.6%. So definitely adding tucatinib has resulted in 36% reduction in risk of disease when compared with the dual HER2 blockade. And moreover, the CNS PFS in patients, I think this was one of the subset which did focus on the CNS progression-free survival, a benefit of 4 months is seen. Definitely adding tucatinib, maybe we can still wait for the OS data to pop up. I think this seems quite considerable to take into account and maybe future, it might be a practice-changing trial. So again, extension to this, we had the HER2 CLIMB O2, which were mainly focusing on the brain metastasis patients. Whenever post-dual HER2 blockade progression, TDM1 was the standard of care. Now, along with TDM1, by adding a TKI, did it make a difference was the question. The intracranial overall response rate was almost 62%, with the median progression within the CNS metastasis was almost 11.9 months versus 6.8 months. Definitely, this also can be a redefining standards, especially in patients. The previous trial did take up the patients who had no brain metastasis, but this patient, even in patients who had a good brain metastasis, there's an increased incidence of penetration by the tucatinib, which says that there is intracranial response almost by 62%. So moving on to the next one. So we are going into a subset of metastatic hormone positive as the trastuzumab govitecan, which is widely used in case of a TNBC. Now its role in case of an hormone positive setting. Here, the main consideration, if you look into the patients enrolled with 690, The patients had a prior exposure to the endocrine therapy along with or without the CDK4/6 inhibitor of choice. The subset mainly included were the endocrine resistant population. I think most of us would question that currently we have the ESR1 mutation testing, or let it be the AKT or PIK3 pathway. So why did they use a sacituzumab govitecan in this subset of patient? This subset was mainly an endocrine resistant population which they had taken into consideration. So here, sacituzumab govitecan, which was given 10 mg on D1 and D8, compared with the standard physician of choice chemotherapy, let it be capecitabine or taxane. Primary endpoint, again, the progression-free survival, and the secondary were the overall survival, along with the quality of life. Moreover, the median follow-up duration was almost 15 months. So what was it, a positive trial or was it a negative trial? If you're looking into the graphs of the progression-free survival and the overall survival, I think the hazard ratio being 0.85, statistically, definitely here we have various other approaches also currently. Maybe using sacituzumab govitecan at this juncture, I think we are not quite correct, as statistically and numerically it didn't show any benefit. And similarly, if you're looking into OS, I think this is one important curve which we need to look in. If you're looking into the PFS, this didn't meet a statistical significance. But here, maybe initially, maybe 6 to 8 months, I would say yes, considering it was not a good option. But as the duration has progressed, the curves are quite well separated. So this indicates that there's an early trend which has been seen. So maybe there might be some subset of population which has done quite well, especially the endocrine resistant ones. I think in those cases, this seems like a good option than adding anything. Of each of the arms of the treatment physician of choice and the sacituzumab govitecan, definitely the duration of response was with sacituzumab was 12 months versus treatment physician of choice of 9.3 months. Here, there is a longer durability with sacituzumab govitecan. I think that would be the main important consideration of trial. It's not the response, but the persistent duration of response was quite higher on this arm, which indicates that a high ADC crossover may confirm the overall survival also. So even though it didn't meet the primary endpoint, but there is showing a consistent durable response. So the question would be, if this consistent durable response has been seen, can this be implemented in a clinical practice? So moving on to the next trial, one of the other important trial is the EMBO-3 trial. As we are quite aware that in post and an adjuvant setting of ER/PR positive patients, advanced breast cancer patient, post CDK4 exposure failure, what are the therapies do we have? So here, the study which shows that it had three arms. They had a second generation SERD where imlunestrant 200 mg was given versus the standard endocrine therapy. And then they had one more arm of combination of imlunestrant with amoeba-cyclib. So this indicates almost 300 patients were given in each of the arm. Primary endpoints were PFS. More importantly, they were even the ESR1. So this is one of the predictive biomarker-driven study. I think now we are moving into an era more of precision and predictive therapy. Here, the testing of ESR1 mutant patients were taken into effect. The secondary endpoints were the overall survival, the safety, and the overall response rate. And if you're comparing with each of the substrate, what did that demonstrate is, yeah, if you're looking into the substrate where the second generation versus standard of care, definitely after certain time, see, if you're looking into most of the trials, initially the Kaplan-Meier graphs are almost colliding. But as they go beyond 6 months, definitely there is a benefit which are being seen with a second generation SERT compared to that of the standard of care immunotherapy, with a significant p-value being 0.0007 and an hazard ratio of 0.62. And again, if we compare the similar one if you're looking into the interim overall survival, almost patients with ESR1 mutation did fare better when they are receiving a second generation SERT compared to standard of care. And this had doubled by using a CDK4/6 in a combination of this. So again, the question comes when we use a SERD along with a CDK4, what about the safety profile, the clinical implication? Definitely the combination, we are quite aware the
Nihanthy, you have 1 minute to go.
Yes, sir, I'll complete, sir. So this study also concluded that it had a meaningful PFS improvement in this. So a brief detail on Evera trial. Again, this was one of the other study which says that post-progression, what are the options? We had Girdistan and the everolimus. Definitely this showed that there was a benefit in the PFS which was noticed around. So as we won't have much time, I'm just going to rush up briefly with this. What was the conclusion of this? There was a meaningful PFS which was seen especially in endocrine resistant setting in ESR mutant cases. So this I'm just going to conclude my presentation by saying that SABCS also the focus was on various mutation marker, predictive and biomarker therapies with ctDNA clearances. Various analysis also was taken part into consideration of the biosafety profiles. And just a brief note, like how the artificial intelligence has changed everything. The final clinical implications of whatever the domains we are using in histopathology, radiomics, or predictive analysis was mainly moving towards learning oncology and integrating this in more to a precision level. So thus, I would like to conclude my talk saying that hopefully with the future development and the overall data, all these will be implemented in the future NCCN and the ESMO guidelines also. And definitely every drug, its toxicity, the resistance, and the economic feasibility and health economics need to be considered and taken into account. So these were the main highlights of the SABCS. With this, I would like to conclude my talk. Thank you.
So thank you, Nihanthy, for the excellent talk. As I said earlier, the conference went for 4 days. To summarize everything in a 15 minutes talk is going to be difficult, but you did an excellent job. So moving on, we have a panel discussion, and we have Dr. Erika Hamilton, Dr. Sarah Sammons, and Dr. Senthil Rajappa already joined, and Dr. Komal and Dr. Erika are on their way, and I'm sure they will join soon. So let us start. I hope my slides are visible. And let me start with is it visible? Yeah.
Yes, sir.
Yeah. So let me start. I have no conflict of interest. This webinar is meant for practicing oncologists, and almost 170 odd are right now online. To help them to make better clinical decisions, we appreciate efforts taken by clinical trialists and thank all patients who participate in clinical trials. No trial is perfect. All trials, be it positive or negative, add to knowledge generated and help in improving patient care. So moving on, we have this first of its kind trial in which oral SERD was tried in an adjuvant setting in a head-to-head trial in high-risk early breast cancer patients. Giredestrant was compared to the standard of care endocrine therapy. They called it standard of care, but it was only endocrine therapy. There were no CDK inhibitors. Of course, the trial was a positive trial, hazard ratio of 0.70, and you have a clear-cut IDFS benefit. But the question comes, as has been shown here repeatedly, that nearly 80% were node positive, more than 30% were N2, N3, none received CDK4/6 inhibition. So let me start. We have close to 4,000 patients. Apart from 100 patient subset, which they have a separate subset in which they gave CDK inhibitors, probably to assess the toxicity part. None of the other patients received CDK inhibitors. So does that make interpretation of this data difficult? And let me start with Dr. Senthil, and then Dr. Sarah can take this. And why do you think they did not combine it with CDK inhibitors? What are your thoughts behind this, Dr. Senthil?
So Amol, so the first thing is there is a giredestrant plus abemaciclib study in high risk early breast cancer that is going on. So we will wait for those results before we say that the combination is better than using just the standard of care endocrine therapy. So that's answer to one of your questions. The second thing is, why did they not give it? I really don't have a good answer to that question, though there is a trial that's running. So maybe at the time that this trial started enrolling, maybe this was not standard of care, or we just had early results from the monarchy, probably. Many physicians and patients probably didn't believe that the small delta that you had in terms of IDFS when these trials started enrolling was worthwhile putting patients on this. In fact, as you rightly pointed out, a set of patients who were taking a CDK4/6 inhibitor were taken off. At least in the first 3 months, they were allowed to take it, and then they went on to get onto the study. So I don't think I have a good answer to say why it was not given. But all that I can say is these are multiple reasons that could probably in part explain why this trial did not have a CDK4/6 inhibitor. But for me, the more important question is, does this make the data interpretation difficult? I don't think so. So the question that this trial was asking is giredestrant better than standard of care endocrine therapy? That's it. So for that question, I think it had a valid primary endpoint, and the endpoint was, positive. So I don't think we should try to cross compare it with what would have happened if it was standard of care endocrine therapy plus a CDK4/6 inhibitor. I think that's probably not the right way of looking at this data and interpreting this study. So for me, simple, straightforward question has been asked with a valid, endpoint, and that endpoint is positive. So all that we can say, giredestrant is better than standard of care endocrine therapy in this set of patients. So that's how I would.
Dr. Sarah, do you agree that the standard of care, that the word that is repeatedly being used, has moved on from only endocrine therapy? It is moved on to AI plus CDK inhibitors. That is a combination that we give. So what's your take on that? How do you think it's make good
Yeah.
this data difficult?
So I agree with everything Dr. Senthil said. I don't think that we can be so black and white, though, to say that the standard of care has changed. I think to answer one of your first questions is why wasn't CDK4/6 added? I was going back. This trial started enrolling in August of 2021. We didn't see approval of abemaciclib in the US until November 2021, and that was only in the Ki-67 high population at that point. The curves were still, separating. There was still, it just wasn't the current standard of care when this trial began. And so I do think in breast cancer, we're a little bit of a victim of our own success as the field just moves so fast, and then we're sort of caught up with what to do. In terms of, I was very surprised by this data. I think this is paradigm shifting. I personally didn't expect in an endocrine sensitive population for a SERD to beat the standard of care that we've had for the last 25 years. And that's what we've seen here. We've seen the ability of a SERD to improve the IDFS in an endocrine sensitive population. And so there are many, many other phase 3 SERD trials underway. This is just the beginning. But I think that this is telling us that we will have a new endocrine therapy option in the future. Maybe not today. We'll have to see what the regulators do. There are many other phase 3 trials underway, but this is paradigm shifting in that SERDs can work in the adjuvant setting.
Thank you, Dr. Sarah. So moving on, if you see the side effect profile, and this was discussed that if you see the rates of arthralgia for the oral SERD giredestrant versus the AI, that is standard endocrine therapy, are more or less same. So probably, yes, the side effect profile are similar. It is more efficacious, but at the same time, it's more costly. So again, the question comes, how are you going to use this data, if at all the data is significant, in, say, on our practice in day-to-day clinic? And there were 2 polls, one done by me and one done by our friend, Dr. Paolo. And this question was asked that if it is available, are you going to use it? And a lot of people were reluctant to use it. Some people say yes. So Dr. Erika, your thoughts on this? How are you going to use this data provided, suppose this gets approved?
Yeah, I mean, I think, the AEs look surprisingly the same to me. And I say surprisingly because I'd kind of hoped that the oral SERD might be better in arthralgias, hot flashes. And then I assumed it was probably going to be a little bit worse in terms of GI toxicity. And they looked the same. Now, I think the individual oral SERD, it's going to compare favorably compared to CDK. We know when we add additional agents, we add more toxicity. So I agree. I mean, I think right now the standard of care is our CDK. We have longer follow-up, we have, OS, et cetera. But there are going to be patients that don't want to do CDK, or there's going to be patients that try and can't tolerate. And I think it's really nice to fall back on giredestrant with, already about a 3% benefit. I'll also maybe just point out that EMBER-4 and some of the Cambria trials are coming, other oral SERDs where the CDK was actually baked into the trial. So I think, this is just because this was one of the first ones to start. We're a little behind now.
So basically, if it gets approved, as one of the options in this polls is that you give CDK inhibitors for first 2 years or 3 years and then switch on to the oral SERTs? How you think it will happen in future?
Yeah, I mean, I don't
If
think
you
that
wanted to
that's
see your
necessary.
crystal ball, your famous
Yeah,
crystal ball.
I don't think that that's necessarily appropriate for everyone. You know, I mean, the question is what is going to be the residual risk after we kind of already risk reduce with one or the other? But for somebody that's super high risk, multiple positive nodes, I think that's probably a reasonable strategy.
So now look, moving on, this is of course a cross-trial comparison of the current data of lidERA trial compared with Monarch E and NATALEE and ATTACK at a similar time frame. And if you see, the delta of the absolute benefit is more or less same, 2.8%, hovering around that point. So let me ask Dr. Senthil, do you think that the gildenstern alone will have same magnitude benefit as the AI plus CDK4/6 inhibitors eventually, or maybe it will do better, or do you think it will maybe worse due to added toxicity? Of course, we have future trials, but looking at this particular point of view, the delta seems to be same for a single agent gildenstern versus if you do cross-trial comparison, AI plus CDK4/6 inhibitors. What are your thoughts, Dr. Senthil, and maybe
I think it
Dr.
might
Sarah,
be
Dr.
as
Komal?
good.
Komal has
It
not
might be
read
as
it.
good as what I feel, Amol. The reason why I'm thinking so is because, you're looking at the first 2 years, which is when you're wanting to prevent this primary endocrine resistance, which is where we think the CDK4/6 inhibitors have made a big difference. So I have a feeling that it might be as good. I'm just making a wild guess. I may be right, I may be wrong. I doubt that it'll be better. My hunch is that it might be as good or probably a tad lower than that, but I don't think it is likely to be better because as you go by, we know that there is a carryover effect of the CDK4/6 inhibitors beyond the 2 years or the 3 years, depending upon whether you use your NATALEE or Monarch. While you're going to miss this component as you go by in the giredestrant monotherapy study. So I don't think it's going to do better. It may be as good, or maybe a tad lower compared to what you're getting with the CDK4/6 plus the hormonal therapy. So that's a guess.
Dr. Sarah, your thoughts on this? Will it be better or worse? Maybe added toxicity?
I think it's unlikely to be better, but then everything, like you said, is going to be a risk benefit. There are plenty of our patients who, once you discuss with them the risk benefit ratios of adjuvant CDK4/6 inhibitors, choose not to do it, especially the more intermediate risk patients. And so this could be a nice option for them, but I doubt it will be better.
Okay. So these are the future trials. As someone has said, that Cambria 2 is the only trial in which they have allowed CDK4/6 inhibitor. The rest of the trials have not. But as everybody's saying, that we'll have to see as the data matures what happens. But probably I feel that it may not be better than the AI plus CDK4/6 inhibitors, but only time will tell us. And of course, we'll look forward to the Cambria 2 trial. Now, moving on.
Amol, can I ask a question? Sorry if I'm allowed.
Please.
Right, so either Dr. Sarah or Dr. Erika, in the metastatic setting, we've always been explaining the superiority of a SERT to fulvestrant based on ESR1 mutations. But I don't think that explanation will be valid in this setting because we know that the likelihood of finding out an ESR mutation is, 2%, 3%, somewhere around that. So is there some good biological explanation as to why this trial was positive, or is it just that giredestrant was better than tamoxifen or an AI?
Yeah, I mean, I'll start. I'm not a big fan of ESR1. I mean,
Okay.
I think it's just the best surrogate we have to predict who's still endocrine sensitive. So as we move up into earlier lines and kind of everyone has endocrine sensitive disease, in some ways that's the purest place to actually test a novel endocrine therapy, if that makes sense.
Okay.
I agree.
Okay. So moving on to early triple negative breast cancers. And whenever you talk about triple negative breast cancer, there is always a question of whether to give carboplatin or not, even though it is one of the cheapest drug available. It has some toxicities. So this San Antonio also, we have a trial presented about use of carboplatin. And this is a summary slide. Almost 5 trials have tried to answer this question. We have 1 trial from our own institution, that is Tata Memorial Hospital. 4 of 5 trials show improvement in long-term outcomes, 3 with OS improvement. So Dr. Senthil, this of course in Western countries, most of the patients have access to the IO, so the question doesn't come. Everybody follows Keynote 522, where carboplatin is part of it. In India and other part of the world, probably IO access is not great. So in those patients, especially stage 2, stage 3, do you think there is a role of carboplatin? Yes or no?
Yes, Amol. I certainly think there is a role for carboplatin, irrespective of whether you're using the Keynote 522 or not. clearly, trial after trial have shown that the PCRs are better by about 15% to 20%, though it's not a good surrogate for EFS or OS, but we still look at that as a sign of biological activity. So that's certainly better, and that's very consistent. The EFS is better in the Tata Hospital study, though for the intent to treat, the overall survival was not better. For the younger premenopausal women, the overall survival was better. So I think it's a consistent signal that carboplatin is definitely adding to the outcomes in patients with early triple negative cancer. So as part of neoadjuvant regimen, whether you're using immunotherapy or not using immunotherapy, I think clearly there is a role for carboplatin there. I think the more interesting question for me is still in our part of the world, a lot of patients get upfront surgery for triple negative cancer, which we would say no, but it still happens. There's a very nice Chinese study that's published a couple of days ago in the JCO, 700, 800 patient study, where they've looked at patients T1C and beyond, patients who've had triple negative cancer, including the ER lows, the less than 10% ERs. And they've clearly shown that there is a benefit in terms of event-free survival and overall survival. So for me, that adds to the body of evidence that carboplatin has definitely got a significant role in these patients. So now I'm starting to think that if I see a rare patient who's been operated upfront, I'm going to start carboplatin for that set of patients also, because we know that these patients do poorly, and this is our only chance and our best chance. So do everything, throw everything at your patient so that you will prevent a recurrence. So we've now got reasonably good evidence, though a Chinese study in that population, that outcomes are better even if you do carboplatin in the adjuvant setting. So that's how I would summarize that.
So Dr. Sarah, what's your thoughts for stage 1 TNBC? Of course, we don't use Keynote 522 regimen. So do you use carboplatin for stage 1 TNBC also, looking at the toxicity? And do you think that in future, maybe we can have, maybe drop anthracyclines instead of carboplatin for early TNBC?
Yeah, great question. At this time, we send stage 1 triple negative patients to surgery upfront generally. I will say for the larger T1Cs, our nebulous cutoff is around 15 millimeters. We will give them neoadjuvant dose-dense AC and Taxol. We generally don't add carboplatin, and as long as it's stage 1, we generally don't add immunotherapy. Because stage 1 triple negative patients still do quite well. If you look at NCDB studies, they certainly need chemo, but they do quite well. So we are not adding pembro, we are not adding carbo for these patients. I'm certainly open to an anthracycline-free regimen for these patients. For the smaller stage 1 tumors, we generally will do a taxotere cytoxan. For the larger T1Cs, we'll do dose-dense AC Taxol.
Yeah. So now moving on, the new 2 studies were presented for early stage triple negative breast cancer and for BRCA mutated subset, and with PALB2 mutated subset. We have 2 studies in which a combination of PARP inhibitors and IO was used. One was niraparib and dostarlimab, and another was having olaparib plus durvalumab, with a PCR rate of close to 80% in the combination of olaparib and durvalumab. So Dr. Erika, do you think, Dr. Erika Mehra is not joined, so Dr. Erika Hamilton, do you think this is the way these things are moving, that in a BRCA mutated patients of early stage triple negative, we may have a combination of IO plus PARP inhibitors? Of course, it's a phase 2 trials, but what are your thoughts on these 2 trials?
Yeah, I mean, I think it's really exciting, right? I mean, this is kind of personalized medicine at its finest. Instead of kind of giving these patients a lot of chemo and then salvaging people that don't have a response with PARP on the back end, it's really giving them PARP and immunotherapy up front. I think the other advantage in these patients that have BRCA mutations is that, giving them a lot of chemotherapy is detrimental to the future as well, because they're more likely to have subsequent cancers, et cetera. So, I mean, I think this data is quite encouraging and, may give these patients an opportunity to receive less chemo.
Okay. So I think Dr. Komal has joined. Yep. Hi. Any thoughts on this? Addition of PARP inhibitors and IO for BRCA mutated early stage triple negative breast cancers. 2 phase 2 trials were presented.
Yeah, exactly. It's exciting data. It's good data to see that there could be a potential chemo-free option. Certainly, these are smaller studies and important for us to get that data. I don't know if these are practice changing and going to be available right this moment, but certainly in the right direction.
So looking forward to this data. Of course, as I said, the phase 2 trials, maybe phase 3 are underway. So moving on, the most exciting part of the breast cancer discussion nowadays from ESMO, from ASCO to the ESMO to the SABCS, HER2 positive metastatic breast cancer. We have 2 trials. We have Destiny Breast 09, TDXT plus pertuzumab, which has got approval as of yesterday. So it is approved for first-line metastatic HER2 positive breast cancer. And that was for Destiny Breast 09. Then we have Patina trial, in which the THP was given as an induction, followed by palbociclib as a maintenance, along with, of course, hormonal therapy for HER2 positive metastatic breast cancers who are also hormone receptor positive. And the new trial, we have, of course, the PI with us. We have HER2 climb trial, in which these particular patients of metastatic HER2 positive breast cancer were given induction THP 6 to 8 cycles. Those who have got a good response were put on maintenance therapy. And the maintenance therapy was, of course, tucatinib plus tucatinib therapy. And it is a positive trial. We have very good curves. PFS hazard ratios are significant. So let me straight ask Dr. Erika, do you think that the control arm has underperformed? Or this is one of the criticism of the trial?
Yeah, I don't
What's your
think it's
thought on that?
underperformed. I think it's a different population, right? I mean, I think there may be some inherent bias of who would go on to enroll, with an ER positive trial with Palbo versus who's getting an additional HER2 agent in terms of kind of disease burden. The other thing that I don't think some people are kind of thinking about is that in HER2 Climb 05, we started measuring after however many cycles of induction they got. So we really need to add on an additional 6 months if you're kind of, looking at the total amount of time somebody got in the first line setting. I mean, on the other hand, I think Patina, I mean, those numbers were very impressive. These were all patients that had hormonally driven disease. The control arm did really well. The experimental arm did too. But the hazard ratios, the kind of, that relative benefit was pretty similar between trials.
Yeah. So now moving on, how to use this data. We are in the era in which have 3 options: Destiny Breast 09, we have a Patina option, we have HER2 climb option, which I'm sure it will soon get approved. So there was again a poll conducted, and if you have a base, it's a de novo HER2 positive metastatic breast cancer patient with a liver metastasis or with a brain metastasis, what will be the choice? So now this is where the expert opinions is important. And the overall discussion till now was that if you have high volume disease, you start with DB09, you use that till at least the patient gets a good radiological response, and then give maintenance. If it is a hormone receptor positive, consider for palbociclib. Hormone receptor negative, consider for tucatinib. If it is a low volume disease, start with the THP and then take a call based upon how good is the response, and then based upon the hormone receptors. So let me straightaway ask Dr. Sara, do you agree this approach, or how we are going to do this? When you have all the drugs available, which you have in your country, so how are you going to go about it?
Yes. So I'm a very simple person. So I like to think about this as induction, or what am I going to start the patient with? So let's start there. The patient that I'm going to start with Destiny Breast 09 as of yesterday is a patient that's highly symptomatic, has heavy visceral disease, has, appreciable CNS disease, has recurrent disease within, let's say 12 to 24 months of their adjuvant trastuzumab with or without pertuzumab. So those are the patients that I'm going to think about a Destiny Breast 09 strategy. I don't believe in Destiny Breast 09 induction, meaning Destiny Breast 09 6 to 8 cycles and then transitioning to maintenance. We have no data to say that that is efficacious, and I would argue that the DB09 was so positive because patients got continuous payload for an average of 20 months. And so if you're going to choose DB09, I certainly think you need to go until maximum response or intolerable toxicity, whatever that is. versus, a patient that you're really worried about who's tolerating it well go until progression. I would still, certainly for ER positive patients, patina, the PFS is 44 months. So de novo, low volume, ER positive disease, I'm going to want to use patina, and I'm fine with a taxane induction. I don't know if my colleagues feel any different.
So Dr. Erika, what's your thoughts? Dr. Erika Hamilton.
Yeah, I agree a lot with Dr. Sammons. I mean, I think the mistake is going to be to do TDXD for 6 cycles just because that's what we did with THP. I too would treat to maximal response. Our CRs in DB09 were about double. I don't think we want to miss out on anybody getting a CR, and we know that the HR positive patients actually take longer to get to that deepest response. So whether that's 9 months, whether that's 16 months, I'm going to treat to maximal response. But I do think we're going to be looking at maintenance in the first line setting. I think just because that wasn't a part of the trial, probably not going to be much of an appetite to continue, trastuzumab deruxtecan for 3-4+ years.
So basically, see, prostate cancer has this concept of high volume, low volume disease, and their trials are designed accordingly. Breast cancers, we don't have this concept. So when you talk about induction chemo, and we, of course, as everybody's saying, that you choose DB09, you try to give it till you get maximum possible response. So the next question comes: suppose the patient achieved CR and he has no toxicity. Would you like to continue, or you like to stop that and put him on maintenance?
You can put
I'd
them on
probably like a second.
maintenance. Yeah,
Would you like a
after a
second CR
confirmation.
with the CR? Would you continue to confirm the CR and then
Absolutely.
drop it, or?
Absolutely.
Yeah. Agree.
Okay. So another question: that most of these trials, the choice of therapy now everybody's saying is based upon the volume of the disease at the baseline. So are we considering MRI brain at the baseline for all? Dr. Komal or Dr.
Yeah, we're not currently doing that for all. There is definitely a big discordance between what our guidelines suggest versus what the EANO guidelines suggest as well. So it's not uniform around the globe, which is an issue. This is a very important question that is being addressed across multiple clinical trials, and we hope to have that definitively from clinical trials that are being conducted. But yeah, I think all of us would agree that our threshold for getting an MRI has certainly changed. And certainly depending on the disease burden or, the age, we do have our own inherent biases. Do we do that for all patients consistently? We're not, because our guidelines are kind of mixed. In fact, the current ASCO publication that we had from the brain metastases group did not support or suggest that we do that for all. But I think all of us have recognized that this is an issue, especially for HER2 positive and triple negative breast cancer, where we are asking patients now, do you have a headache? Or we're justifying a low threshold to obtaining these. The one question is, are we doing them at baselines? The other question is, are we consistently doing them even while on therapy, right? And both are not consistently happening in all practices, but they are definitely being addressed in research trials, and hopefully one day will be all homogeneous in our practices.
Dr. Lin and I just published an editorial with our opinion that when doing a brain MRI is going to impact your treatment, it should be done. And so I am of the opinion that brain MRI should be standard for HER2 positive and triple negative breast cancer patients, because it would have strong implications for what treatment the patient gets. So hopefully we'll see guidelines catch up to current practice considerations.
And then how often do you repeat them, Sarah? Was there a suggestion on that as well?
So that's the gray area. So no, we don't know. Certainly if they don't have brain mets, maybe you do it once a year. But if you find brain mets, then you're going to continue screening at regular intervals.
Yeah. So now moving on, maybe in near future we'll get an approval for early use of trastuzumab deruxtecan. So Dr. Erika, what's your thoughts that if you're using it early, how all this data will be useful, because none of these patients have those patients who have used these drugs in an earlier setting. So Dr. Erika, you have to unmute yourself. Yeah.
Oh, the other Erika is no longer here. Hi, everybody. Sorry to be late. So I think the data from DB05 and DB11 presented at ESMO this year was incredibly exciting to think about the transition of TDXD into earlier line settings. And considering, first of all, the consideration of how we will use that in practice, whether it's best offered to patients in the preoperative setting or we reserve TDXD in the postoperative setting for those with substantial residual disease after preoperative therapy. I think those are questions that we are still trying to consider in our clinical practice and with our internal guidelines. But it does raise the challenging question of, for what will hopefully be a small group of patients who might experience disease progression after pre or postoperative exposure to TDXD, how are those patients best managed? And we don't know. But like we have addressed with other novel therapies that have moved into the earlier stage settings, some of that may depend a bit on the timing of recurrence, whether that is within 6 to 12 months of exposure to TDXD or a longer time out, and the degree of disease progression and how substantial or symptomatic a patient might be. I think for a patient who has received TDXD within 6 to 12 months and then has metastatic recurrence, I would be very worried for that patient. I think that would symbolize a fair amount of resistance, and that the activity of TDXD, again, I would be guarded about the optimism that it will be active. But I certainly hope that we'll have novel ADCs in that space that may be able to overcome resistance, and perhaps using different ADCs may be a preferred strategy. But that's going to be one of the new research questions that we will need to address.
Thank you.
Hopefully that scenario is not that common.
What is said and done, the use of TDXD is going to grow up, and in your part, of course, you have more access to these drugs. So let me ask you very practical questions. Do you wait for CT scan resolution of ILD or clinical improvement is okay to re-challenge for a patient who had got grade 1 ILD because of TDXD, and you take a pause? So how you do it practically? And if you re-challenge, do these patients end up getting more severe ILD? How many of them? So how do you decide whether you want to go re-challenge or not after grade 1 ILD for those patients who have on TDXD? So, Dr.
grade
Sarah?
1, oh, sorry, yeah.
No, it's okay.
Historically,
So,
we've been very... Yeah, go ahead, Sarah.
No, go ahead, Erika. I was going to say, I generally stop the drug, rescan in 4 to 6 weeks and wait until resolution. And as long as it was grade 1, then we have data that it's safe to re-challenge. Some of them will develop ILD again, but many will not. And we saw some of that data by Dr. Rugo's team this year at this conference. And I think it's going to be a risk-benefit ratio too. I mean, re-challenging patients in the metastatic setting is different than re-challenging patients in the adjuvant or early stage setting. So yes, I absolutely re-challenge in the metastatic setting where the risks are great for holding therapy. But I have not been confronted with this in the early stage setting where re-challenging the bar would be a lot higher for me.
Dr. Komal,
yeah, I agree with that, and would also add that if you are re-challenging after a prior grade 1 ILD, I would be extremely careful with first CT scan 6 weeks into treatment, with collaboration with pulmonary if necessary, consideration of dose reduction up front if necessary. And if the patient had grade 2 ILD, I would not be re-challenging. And I think Dr. Rugo's real world data supports that this is really only an option for prior grade 1.
I'll just add for a clarification reason that grade 1 by definition does not have symptoms. Grade 2 is symptomatic with imaging findings. So I think the only way to think about resolution and re-challenge is based on the radiological findings, because that's what grade 1 by definition is. And I think we re-challenge at the same dose, or could re-challenge potentially at the same dose if the resolution was within 4 weeks. If it takes longer, if it takes more than 28 days, it takes longer than 6 weeks, we automatically want to dose reduce that. And then certainly be more careful if it took that long to do that. So I think very, very important to remember that. And for grade 2 symptomatic, it's automatic discontinuation. It's no point thinking about re-challenging the patient. This is a big trigger for fatal outcomes, and you would not want to do that with grade 2.
Yeah, thank you. Thanks. So moving on, metastatic triple-negative breast cancer. Again, we have the ADCs coming in the earlier line. We have algorithms getting changed, and this is the latest algorithm. So, Dr. Erika, do you think, so what's your thoughts on HG versus Dato-DXd for the first-line metastatic triple-negative PD-L1 negative? Do you agree with this algorithm? This was, I think, given by Dr. Sarah Trelawney, if I'm not mistaken. Yep.
Yeah, so we saw this really exciting data at ESMO this year, looking at two trials, ASCENT-03 and TROPION-Breast02, moving a TROP2 targeting ADC into the first-line setting for metastatic triple-negative breast cancer for whom you would not be giving pembrolizumab. And both of these were positive trials showing significant improvements in progression-free survival, which was incredibly exciting, as well as improvements in overall response rate. I will point out that TROPION-Breast02 also had an overall survival advantage, which was not seen in ASCENT-03. But an important detail in ASCENT-03 is that the trial offered crossover to SG at time of progression. And that is likely why there's no detectable overall survival advantage, which in TROPION-Breast02 was not a possibility for patients. I really love this table that you list that Sarah Tlaney and Ana Greta Castro had put together that helps us understand the patients for whom we might be thinking about SG versus Dato. The Dato trial, the TROPION-Breast02, did include a small population of patients with early relapse after initial early stage therapy. This is a really challenging group of patients. If patients have, let's say, keynote pre-op and then recur soon afterwards, and we know those patients have very resistant disease and are often excluded from clinical trials. So it was terrific to see a population of those patients included in TROPION-Breast02. So, I think that's an important detail. Additionally, the side effect profile is quite different between these two drugs, where if a patient has difficulty with cytopenias, is looking to avoid significant alopecia, or has difficulty coming for weekly treatment, that's a patient for whom Dato may be a preferred option instead of SG. So, I think that my takeaway from this data from ESMO is it really reinforces the importance of a TROP2 targeting ADC in the first line setting. But as to which one to select, I think that becomes more of a patient-specific conversation.
So in
Only
future,
thing I want to
yeah,
go
please,
ahead.
Sarah. Yeah.
I just want to add TROPION-02 included 64 patients with brain metastases, and the hazard ratio favoring Data in those patients was 0.3. And so I do think Dato DXD, like TDXD, is very active in the brain. And so I would prefer it for those brain mets patients too.
That's a great point.
Yeah, thank you. Thank you. So, as the discussion was going on, Dr. Komal, do you think that there is what about this particular population, as it was touched by Dr. Erika also, that those patients who may progress post Keynote 522, that means they have already received Pembro and then they have progression. So, what will happen to them? What will be because only 5% of those patients were both of these trials. That means TROPION-02 as well as ASCENT-03.
So right now we don't have definitive data for that, but I think we would still reach out for the same tools that we will have available in clinic, which would include ADCs. I think, we have been using ADCs post IO in the second line metastatic setting as well, right? Up until now, we were doing that for PD-L1 positive patients and utilizing the ASCENT data to justify an ADC at the back end. Clearly, for this very poor prognostic group of patients who, despite the Keynote 522, have recurred early, I think, short of ADCs, the other options are even weaker. So I would certainly still reach out for ADCs. It would have been nice to have understanding of what that PFS or what that benefit would look like in such a setting. Just because we don't have that does not mean we can't use what we will have. And I think I would still do the same.
Thank you. Thank you. So moving on, let's come to the trial that you presented and the PI. Yes, unfortunately, the trial is negative, but do you think any positives from the study, and why you think that the Sesudang did not work in this particular setting? We all like to know from you.
Yeah, no, I think it was clearly a disappointment to see that it does not meet its primary endpoint because we were hoping that ADCs would beat chemotherapy in every setting. But this speaks to the heterogeneity of ER-positive breast cancer, for one. And maybe also, underscores the importance of chemosensitivity. When the tumors are pre-treated with chemotherapy and we try and compare an ADC to chemotherapy versus when we're, testing upfront chemotherapy with ADCs. That's one. The second most important reason, I think, has been that slight discordance between the locally assessed PFS and the centrally assessed PFS, which we know in ER-positive breast cancer can be tricky, right? But for an open label trial, that's what the FDA demands. But it can be tricky because our investigators would know that, you have ADCs with overall survival benefit available. They would know information about rising tumor markers or pain, which blinded independent review would not. Non-target lesions are not going to be picked up as confirmed resist progression by blinded independent review, but will be determined progression, which is what happened. There were more patients with new liver lesion, which probably would have been confirmed with the resist BICR read, but not with local. And there were more patients with pleural effusions. Also, there was censoring in the first 4 months also, where higher proportion of patients in the locally assessed TPC arm, required new anti-cancer therapy, including ADCs. But what was still interesting, despite all of this and despite it not meeting its endpoint, was the overall survival signal, despite the 61% population that received ADC in the control arm. So more patients, double the amount of patients, got an ADC, which we know have overall survival benefit. Despite that, the overall survival trend is favoring the SG arm. So if you think about TROP2 ADCs, the delta of benefit in PFS has always been very narrow, right? Unlike TDXD, where we see a larger benefit, we saw in TROPiCS-02, the PFS benefit was 1.5 months. In TROPION-Breast01 with datopotamab, despite earlier line, we saw only 2 months of PFS delta. And we did see an overall survival benefit in TROPiCS-02, which was larger than the PFS. It was 3.2 months compared to the 1.5 months. So because of that 2-month delta, I think that this discordance between the local and the central made a big difference. And perhaps the trial would have looked different had we had locally assessed PFS as a primary endpoint. But at the end of the day, hazard ratios are high, 0.78 by local, 0.85 by central. Trial did not meet its primary endpoint. At this point, we cannot use SG as first-line chemo, but we certainly have it available in the second line and beyond.
Definitely. Thanks for your views on this. So moving on, the place where all the new drugs, all new trials are coming up, too many of them, a lot of new agents. They say that every 2 or 3 months, new data comes up, and it's all become confusing. At least we in India are happy, Dr. Senthil, we don't have access to most of them, so you're not to be worried. But in US, of course, there is an access to everything. And the median PFS in lateral lines post-CDK has improved from 6 months to 12 months. And as has been said, that the single agent oral sets versus the combinations tend to do better, as this is, of course, cross-trial comparisons. And this is the slide from Dr. Erika's presentation. And as she has shown here, that at least 2 trials, we are able to improve the median PFS from 6 months, which was previously, to almost 11 months. So that comes to this particular question. And Dr. Erika, I want you to take this and make us understand that suppose everything is available, how are we going to decide the volume of disease, co-mutations, duration of prior CDK inhibitors, or you will rely on ctDNA, or you will go for UMBR3, where benefit is irrespective of the ESR1, or of course you will not go for Victoria because there are 3 drugs with 3 different routes of administration, IV, IM, oral. So if you have everything available, Dr. Mayor, how are you going to decide?
So I totally agree with you that this area has become very complicated, and that there is confusion about the different agents and the sequencing and selection. However, I do want us to recognize that this is a benefit for us and our patients, that we will have choices, and that ultimately we will figure out what our preferred regimens are and identify best patients. The figure at the bottom was my attempt to think about how the new data that we're seeing from Serena-6, EMBER-3, Avera, Victoria-1, and Veritac might become approved regimens, and for whom we might have them available. And depending on what is approved and when we're using it, that may have implications on what we decide to select. For example, if we all begin using the Serena-6 regimen, monitoring for the development of an ESR1 mutation prior to disease progression, and switch patients to the oral SERD camizestrant early, then we perhaps may be less enthusiastic to offer an oral SERD combination later, although we don't know for SERD after SERD if there's retained sensitivity and if that's a feasible strategy. I think out of all of the data that's been presented, the slide you showed looking at the Kaplan-Meier curves, this is from Alessandra Gennari's, yes, this slide, her discussion at ESMO. I think this is really compelling because on the left, we have the single agent SERD versus endocrine therapy, and we can see that at time of first restaging, about 50 to 60% of patients are experiencing disease progression. They have endocrine resistant disease that cannot be overcome with the use of the oral SERD. But on the right, we have the data from Avera and EMBER-3 using oral SERD combinations. And we can see that at time of first restaging, we're only losing about 30% of patients. And there's a very early separation of the curves, suggesting using two agents allows dual targeting of both the ER signaling pathway as well as a second resistance pathway, whether that's PI3 kinase mTOR pathway or whether that's CDK signaling. And so if from my perspective, I think this really supports that when we're making treatment selections, we do want to select a combination as opposed to monotherapy. Now, if you move forward 2 slides to the previous one that we looked at, yes, here. So, I am particularly excited about the combination of oral SERD with targeted partner. I would love if we had both imlunestrant and abemaciclib, as well as giredestrant and everolimus as treatment options available. The side effect profile of these regimens is quite different. We are fortunate that the oral SERDs are incredibly well-tolerated medications and do not appear to have any substantial toxicity beyond what we would typically see with traditional endocrine-based agents. There's a little bit of bradycardia, grade 1, that we can see with a few of the oral SERDs. Camizestrant has a toxicity called photopsia, which is a very minor visual disturbance that doesn't affect vision or activities. So it's great that these are really well tolerated. And so the toxicity we see traditionally comes from the partner drug, whether it would be abemaciclib or everolimus here. We do have lots of strategies to manage side effects. We know abemaciclib causes diarrhea. We have ways to manage that. With everolimus, use of prophylactic steroid mouthwash is incredibly important and helpful. And so for me, I would be looking forward to the option of using either one of those agents or combinations in clinic as a post-CDK choice. However, if the Serena-6 camizestrant regimen is available and that one had already been used, then we need to learn more about whether a SERD combination would be active post-Cami CDK4/6.
So Dr. Komal, I think this was asked to you in SABCS also, that do you think that EMBER-3, where the benefit with respect to the ESR1 should be the regimen of choice, because you don't are not worried about whether the ESR1 is present or not, the benefit with respect of that. So what's your thought on that?
Yeah, no, I think there is a clinical thought and then there is a regulatory path, right? And they don't necessarily align all the time. They run in parallel at some points, right? Because, there are different reasons for regulatory approvals and the data sets kind of suggest something different. So based on the data, at least, it does seem that even with patients, with majority of the patients, 65% on the doublet arm that got a prior CDK, the benefit was seen regardless of ESR1 mutations. And, this was the only data set that has shown that the wild type activity was maintained, which is not very surprising. We've seen activity for CDK4/6 inhibitors in wild type tumors in the first line, right? So it's in line with that in some ways. Whether that will lead to approval or just guideline endorsement or a mixture of both, we don't know, because the current filing that Lilly has done is only for ESR1 mutant tumors. So we'll see what the guideline endorsement and access does, given that Abema is already available in the clinic. But if it were to me, I think it would be an option, and I think it could be considered as a reasonable option for wild type tumors clinically for a patient.
So Dr. Sarah, so we have this last Victoria 1 trial in which the 3 drugs are used. One is IV, one is IM, one is oral. Do you think it is feasible for patients to take? So what do you think about that particular thing? What are the patients that you will put on this particular regimen? One is IM drug, one is IV drug, and one is oral drug.
Yeah, well, I mean, the good news is the space is crowded and competitive, and so we have a ton of options for our patients. I think given that we have 2 oral doublet regimens with similar outcomes as this IV-IM oral regimen, I think uptake will probably be a bit less. Now, if we see the gedatolisib triplet in the PIK3CA mutant population go beyond 12 months, then come back to me, because I would consider it there.
Right.
I think some people have made an argument that From a patient point of view, some patients don't want to take pills and they find it easier to come into clinic, get an IV, and then, except for the palbociclib, not have to worry about the other pills. So I think people argue it both ways, but it's complicated to give triplets and monitor toxicity for 3 medications.
Well,
Agree.
I think Dr. Senthil, I want your thoughts on this. This was discussed, I think, briefly by Dr. Erika also. For the young, fit EBC patient, progressive adjuvant abemaciclib plus endocrine therapy, now have lung bone mets. In unfortunately, aggressive disease, 13-month progression, rebiopsy is still ER positive, HER2 1+, no new mutations. How will you go about it?
I think I kind of agree with the choice that the majority have taken in this clinical situation, Amol. We know that if somebody comes back with disease while on the CDK4/6 inhibitor, it is quite aggressive. So we would not want to put them on a hormonal therapy again, irrespective of whether you got an option for a targeted therapy along or not. So I think if you have access to Enhertu, that's the best thing to do in this situation. If you don't have access to, then it's likely to be some form of chemotherapy. I wouldn't really go on to do another hormonal therapy plus targeted therapy in this situation.
Okay. So I think that comes to the end of this fantastic session. We had managed to discuss as much point as we can in 1 hour, and I really thank all my faculty for taking time out from their busy schedules, especially in early part of the day in US, and of course Dr. Senthil for joining, Dr. Sarah, Dr. Komal, Dr. Erika. Dr. Erika Hamilton has to leave early. And Happy New Year to all in advance. And if you have, can we stop sharing my screen? So if there is any significant audience questions, we can probably take that. Or, yeah, in fact, we have 33 questions. So it is too difficult to take that. But I really appreciate all of you for taking time out. And hopefully, I think we can take one question. Somebody has raised the hand.
Sorry, I have to hop off. Thanks for having me.
Yep. So I think that should be the end of it. I won't take much more time of you. I really thank you, all of you, and wish you Happy New Year and a great holidays. And hope to see you in person soon. We met Dr. Erika Mayer last month, but hopefully next year again, maybe for ESMO Breast or some other conference, we'll again meet up with all of you.
Absolutely.
Thank you.
Thanks for having me.
Thanks. Good
Happy
night.
holidays.
Bye-bye.
Happy New Year,
Happy
everyone.
holidays.
Happy New Year, everyone.
And fantastic audience. And I thank all my audience. Thank you. Thanks. Thank you. See you again.